So today's topic of discussion is basics of ECG interpretation, and some part will be recognizing the cardiac emergencies. The aim of the lecture will be to know the basics of the ECG and at least to be able to recognize what are the cardiac emergencies and when we should involve a cardiologist. Something that is very important because in cardiology, the time is everything. You will have to save time. So when we talk about the lead placement of the ECG, previously there were only three leads placed. One was placed on the right arm, one on the left, and one on the left foot. So when we place these leads, we find out that we can find out the difference between the right to left, left to foot, and then right to foot. These were known as the first primary leads, that is lead 1, lead 3, and lead 2. Later on, it was found out that if we want to know exactly what's going on over here, we can give a negative leads in the right foot, and by finding out the difference, we can get an augmentin lead known as the AVR lead. Again, a negative lead connected AVL lead and a AVF lead. So what does ECG do? It gives you a 3D picture of the cardiac circulation. So if we are seeing the heart, it is contracting like this. Now, if you are looking from the front, you can see one wall. Again, from the back, you can see another. Again, you can see other. So ECG will give you a complete 3D picture of that. And with these leads, augmented again with the chest leads, V1, V2, and 3, 4, 5, 6, presented over here, again connected to the negative leads, they will give you a single point description that where the current is going. So when we place the lead, there is a universal code known as the red light code or the traffic light code. So the right lead is the red lead. Next is the yellow. And over the left foot, you have the green. Just like the traffic signal, red, yellow, and green. By placing these leads, you get 10 electrodes are placed and you get a 12 lead ECG with that. One electrode affects to each limb. Historically, ECGs affects to the distal limbs. Then there are 6 leads connected to the chest that will give you V1 to V6 of the chest leads. Again, 3 bipolar leads. The lead 1 right arm to left leg, lead 2 right arm to left leg, then lead 3 left arm to left leg. These leads forms the Eitenhoven triangle and which gives the basic symmetric triangle made for the 3 consecutive leads. There are 3 augmentin leads, AVR, AVL, AVF, and 6 precordial leads, V1, V2, V3, V4, V5, V6. So these are the limb placements. These will make the lead 1, lead 3, and lead 2. Again, the chest leads, V1 to V6 placement. One is on the right and left. So these two, they give the anterior wall of the heart. These will give the septal wall, and these two will give the lateral wall of the heart. Eitenhoven triangle is formed by the 3 leads already discussed. So when we get the ECG tracing, we get it on a graph, and the graph, it has some large boxes and some small boxes. So the small boxes are 1 mm by 1 mm and large boxes are 5 mm by 5 mm. Then everything depends on the calibration of the machine. So ideally, the ideal calibration, it is said to be 10 millivolts per mm and 25 mm per millisecond. What does that mean is that when the film will rotate in 1 second, 25 box will be covered, and when the current will come, the amplitude will be 10 millivolt will give you a 1 mm rise on the amplitude. So the x-axis shows the time in seconds and the y-axis shows the voltage in millivolts. The tracing speed is 25 mm per millisecond, and one small box, if we calculate from this, is 0.04 seconds, and one large box is 0.2 seconds. On the y-axis, one small box will be 0.1 millivolt and 10 millivolts will be one large box. This helps you determine the voltage. The amplitude correlations will electromagnetically coupled events in the cardiac cycles. There is no deflection, then there is no cardiac conduction. Small deflection, low voltage association with thin myocardium. Large deflections means high voltage association with thick myocardium. So this is the graphic representation. 10 mm will give 1 millivolt, and again 5 mm by 5 mm box, 0.2 milliseconds will be there. So what is an isoelectric baseline? So when we get our ECG tracing, we get something like this. So what is happening is when there is no current passing down, it will be flat. Again, when the current is going towards the electrode, it will be a positive deflection. When it will be going again opposite to the electrode, it will be a negative deflection. The flat tracing free of positive or negative deflection is between the waves or the complexes, represents the periods of electrical inactivity of the cardiac cycle. The P wave, it represents the atrial depolarization. So when we see the cardiac cycle, the impulse will start from the SA node over here in the atrium. So it will spread in the atrium first, then through the AV node, it will go to the Purkinje fibers, then to the ventricles. So electrical impulse will go like this only, the first positive wave. So if I am looking at this lead, that is the AVL lead. The first, it will be a positive P wave representing the atrial depolarization, positive deflection in the inferior and lateral leads. P wave represents the ventricular repolarization. So after everything, when the ventricle starts repolarizing, the T waves will come. Then there are intervals, the PR intervals from the beginning of the P wave to the initial deflection of the QRS represents the time needed for the electrical impulse to travel from the sinoatrial node to the atrioventricular node. The QT interval from the beginning of the QRS and the T wave represents the ventricular depolarization, contraction and repolarization. The RR interval, the time between two successive QRS complex used to calculate the heart rate. Then there are segments. The PQ segment is isoelectronic segment between the P and initial deflection of QRS. ST segment is isoelectronic S and the initial deflection of the T wave, and then the TP segment. It is the isoelectronic baseline between the T wave and the initial deflection of the P wave. The QRS, it represents the ventricular depolarization. Components are three: the Q wave, negative deflection; R wave is a positive deflection; and S wave is a negative deflection. So it's something like this. Depending on the ECG lead, the QS wave, positive deflection may not be apparent, or there may not be an R wave. The RS wave, negative deflection may not be apparent or may not be a Q wave. QRS complex, collective ventricular depolarization regarding the presence or absence of all components. So where the lead is placed and how the current is moving, that will decide what kind of complex will come in the different ECG leads. This is an ideal ECG. It has a P wave, the atrial contraction, then the QRS, the ventricular contraction, and then the P wave, the ventricular repolarization. So now the basics of the ECG are done. Let's see how we can read an ECG. So like, looking at a ECG is just like hearing a music. You will have to get the gestard of it. You will have to feel it more like you can read it. It will come with the practice only. It takes time to systematically check the heart rate intervals and the presence of the P waves. There is always a computer representation of the reports. It is mostly right for the intervals, but mostly wrong for the arrhythmias. Heart rate is the beats per minute, intervals the time taken for various ECG components, and the P wave is the electrical signal route made by the depolarization of the atria. So the ideal ECG shows flow of the electrical component, depolarization current. First test to be done, and it is the simplest and cheapest test. It is accurate to identify any arrhythmia, myocardial infarction, or heart rates, heart attacks. Then this is the normal flow of current. the normal anatomy of the heart, there is SA node, then AV node will pass the current to SA node will pass the current to AV node, and from there it will go to bundle of his, then to the ventricles. So this is how the ventricular depolarization occurs. The current goes from up down, then towards the right, and hence we are getting the once a negative, then positive, and a negative wave. The triangle we have already discussed, unipolar leads. Then these are the precordial leads. So when we are looking at the triangle, one thing that we should know, always look at the pairs. So this is lead 3 going downwards, lead 2 going downwards, then there is an AVF lead going downward again. So these 3 pairs, they represent the inferior wall of the heart, lead 2, 3 and AVF. Then we have lead 1 going left, lead AVL, that is purely left, and again these 2 leads, they represent the lateral wall of the heart. Anterior is represented by the V1, V2, anteroseptal by V3, V4. So how to interpret? There are 9 steps to interpret an ECG. The first thing, we should always check for the voltage calibration, because if it is wrong, every calculation will be wrong. Then we will have to determine the rhythm of the ECG, the rate, timing intervals. Each interval has its own implications. Determine the mean QRS axis. Then P wave morphology and evaluate the QRS morphologies. Evaluate the ST elevations and T wave morphologies, and then you will always have to compare with the previous ECG. So acute changes are much more important than chronic changes. If a patient is having ST elevation for last 2, 3, 4 years, every ECG is showing, then it might be a normal finding. But if it was normal in the morning, but now it is showing ST elevation, even 1 mm is quite significant. So when we look at a ECG, we can see that each lead has its own representations. Somewhere R wave is good, somewhere P wave is good. So first thing, we will always check for the calibration. It will always be seen in the left side of a ECG, whichever ECG you are, machine will always give you a calibration, something like this. A box will be there, and you can check whether the calibration is right or no. The right calibration is 10 millivolt, 1 millivolt giving 10 mm, and the half calibration is also there, but it is not usually used. Then we determine the rhythm. The rhythm is determined by seeing the intervals between the two RR complexes. It should always be the same. If it is not, then the rhythm is wrong. The sinus rhythm is present if we have a P wave present. If all P waves are followed by a QRS, each QRS is preceded by a P wave, and PS is identical and upright in lead 2 and AVF. So how do we calculate? There are actually 2 formulas. One is for a normal rhythm. If the rhythm is okay, you can just calculate the interval between 2 RR intervals. You can calculate it, and you can go for 300 divided by the interval. It will give you the heart rate. But if the rhythm is not normal, then you will have to change your tactics. Then you will have to calculate the 3-second strip or 4-second strip. So we know then one large box is 0.2 milliseconds. So if we calculate 3 large boxes, it is 0.6 milliseconds. Multiply it by 100, it will give you 6 seconds. So we can just calculate how many large boxes are there. Just 3 large boxes are there. Then we can calculate how many QRS are there and multiply it by 100. Or by 30, calculate 30 and multiply by 10, whichever is available to you. The normal heart rate will be 60 to 100. Then the timing interval. So each interval has its own normal values. The PR interval, it is 12 milliseconds to 20 milliseconds. Then normal QRS is 10 milliseconds. Normal corrected QT interval is 33 to 46 milliseconds. Then how to determine the mean axis? So there is a beginner's method and there is a advanced method. The advanced method says that you should always see which is the least or most isoelectric lead in 1, 2, 3, and it will be opposite to that lead. So we know that all the leads are perpendicular to each other. So if lead 3 is positive, then perpendicular to lead 3 is AVR. So we can have an axis like towards it also. So it is a complicated method, but to have a easier method, what we have to see, we just see the lead 1 and we see the lead AVF. So if there is a positive deflection in lead 1 and positive in lead AVF, it is a normal axis. If there is a negative deflection in lead 1, so 1 and AVF, both are positive, it is a normal. If one is negative and AVS is positive, then we can see that the direction is going somewhere here, it is known as right axis deviation. If one is positive, AVF is negative, then we are having a left axis deviation. And if both are negative, then it can be a situs interverse, the heart is dextrocardia is there, or we are having an extreme right axis deviation normally found in extensive posterior wall MI. So when we check the P wave morphologies, we look at the lead V1 and lead 2 only. The other leads, the P wave morphology is not of any significance, mainly due to the position. So V1 is placed just above the SA node, and lead 2 is something going in the direction of SA node, that is from right to left foot. The SA node current is also going. So this is the position where P wave is look best. So P waves can have a vertical uplift, and this is normally seen in right atrial dilatations or enlargements. In P pulmonale, it is also known as P pulmonale. In the cardiac, in the respiratory patients or call pulmonary patient, you can see this. And it can be a biphasic in lead V1 with a more negative wave in lead V1. And this is known as P mitral, seen in left atrial dilatations. Now, when we check the QRS morphologies, the R wave transaction is normal in the V3, V4. So what does this want to say is that in lead 1, V1, you can see that there is very small R wave. Lead 2, again very small R wave. And then lead 3, you can say that the R wave is more than the S wave or equal to S wave in some cases. And this is the normal transition. If this is not there, suppose the patient is not having R wave here and here, then you can say that the right ventricle is not acting properly. R wave in V1 and S wave in V6. This will show you right ventricle. S wave in V1 and R wave in V6. This will show you left ventricle. So what is ST depression and elevation? Once we can see the normal ECG, we can understand that this should be equal to this. If the R and S have some kind of depression from the isoelectric line, it is known as ST depression. It can be suggestive of an ischemia. And to look for the ischemia, what we have to see is what is the morphology compared to the P wave. If we continue the P wave as a W and it is coming to the same, then it is not a cardiac ischemia. It can be due to other causes, for example, digoxin toxicity. But if we continue the P wave and it is going down, the continuation is breaking, there is an angle, it is sure shot that there is some kind of ischemia is there. Then we check for ST segments for depressions and elevations. Now let's see a case. So a 22-year-old male presented to the cardiology OPD for evaluation of anterior chest pain. Patient is having discomfort several times each day for 1 to 2 hours. Physical examination, his sternal area is tender. He says he received several blows during a recent boxing match. So he's a boxer, he received some blows to the chest, and now he's complaining of chest pain. We get an ECG done, and we can see by the 9-step examination the rhythm is okay, the rate is almost 70, the axis is okay, positive and positive, no STT changes is there. So this is a normal ECG, and the diagnosis becomes musculocutaneous chest pain. We can give NSAIDs and the patient will be okay. Now let's have a small discussion of how to recognize a myocardial infarction. Something is a very acute condition, and we should always be able to diagnose it very acutely. So when to say that a patient is having a cardiac chest pain? So we will have to learn three definitions here. The first is any pain which is from the lower jaw to the upper umbilicus is a cardiac pain. That is to be understood very easily. If it is epigastric pain or neck pain, even in the arm, if it is pain, it should be cardiac pain until unless proven otherwise. It will be called a typical chest pain if it is associated with radiations, or patient is having sweating, or patient is having shortness of breath. Then it will be known as a typical cardiac pain. And if these typical features are not there, it will be known as a atypical cardiac pain. So whatever, whether it is atypical or typical, if a patient presented with chest pain, you will have to get an ECG done. ECG can have ST changes. STT changes can be elevation or depression. Both can be there, or ECG can be normal. Now, if a patient has a normal ECG and a patient has typical kind of chest pain, you will have to go for a tropi test. And if the ECG is showing any changes, whether it is typical or atypical pain, you will always have to go for the management. What is the management? Immediately we will have to give aspirin to the patient. We will have to give either ticagrelor or clopidogrel, whichever is available. We have to give atorvastatin, some painkiller, which should be a opioid based painkiller, and oxygen therapy. Starting this, then we can call the cardiologist to go for an angiography or PTC or whatever we can go for. But this treatment should not be delayed at any part, at anyhow. Any chest pain, patient should always get a management done, whether the ECG is normal also. When we are waiting for the tropi, we will have to give the loading dose to the patient, because this will give us the time to wait for the tropi reports. The differentials can always be a respiratory conditions, pleuritic chest pains, GI conditions, or musculoskeletal conditions. And we should always get an ECG done in any kind of chest pain. So what does the ECG shows? The ECG will show changes in the T waves, ST segments, and the Q waves. And which part of the, which lead of the ECG is showing this will localize the MI. So this is the normal flow, a normal sinus rhythm of the ECG. Now look at this is the normal rhythm. We can see everything is normal over here. The ECG will always have a prognostic information in the acute MI. It presents as ST elevation repression as well as inverted T waves. So the first change is ST depression if the patient is having ischemia. Once it goes to infarction, he will have ST elevation, and when it starts to heal, it will have T inversions. All three should be considered an MI with a chest pain patient. So this is the lead localization that we have discussed previously also. So the lead 2 and lead AVL along with 5 and 6, it is localized to the lateral leads and the lateral wall of the heart. Lead 2, 3 and AVF, all three localized to the inferior wall. V1, V2 anterior, V3, V2 septal. The ST elevation MI produces more tisular damage and have a worse prognosis than the ST depression MI. Non-ST elevation MI shows ST segment depressions. The ST segment depression can be caused by reversible myocardial ischemia. So when we see ST depression, we can have a breath that it is reversible somehow. So the STT changes we have already discussed. It should always cut the circle. The causes can be ischemia, the abnormalities of hypokalemia, then digitalis toxicity, all of them can shows the ST depressions. Now when we see this ECG, we can see that this is the P wave, and when we continue the P wave, the continuity is broken, there is an angle, but this ischemia is quite less. But when we see this, we can see now the depression is much more. And this is a proper NSTMI with a worse prognosis compared to this. So now talking about the inferior lead, inferior wall MI, it is seen in lead 2-3 AVF, and normal artery is right coronary artery. Now when we go for the this chest leads, we can see the anterior MI, usually the left anterior descending artery is the supply, and the cutoff to different part of the LAD will show the changes in different leads. Then the lateral leads, the normal circulations from the left circumflex or anterior descending artery. Now anterior inferior wall MI, the inferior ST segments, the ST segment elevations in lead 2-3 AVF will be there. Now when we diagnose a MI, something is very important, that we should always see that there is reciprocal changes in the opposing leads. And how to identify the opposing lead? In any MI, the opposing lead is always 2-3 AVF. So whenever we see an ST elevation MI, these three leads will show us an ST depression. The only exception is in inferior wall MI, these three leads will show you ST elevation, and lead 1 and AVL will show you a ST depression. So if you are not seeing ST depression in the opposite leads, then maybe it is not an MI that we are dealing with. So the inferior STMI, there is ST segment elevation 2-3 AVF. We can see ST segment elevations over here, and see that there is depression in lead 1 and AVL also. The opposite leads will have an opposite effect. Now when we see the anterior wall MI, we can see the lead V2, V3, we have ST elevations, V5, V6. So the inferior leads are not seen there, but we will have depression in lead 2, 3, AVF. To any chest pain patient, the classic way to see is, first thing you should always see these three leads. If the STT changes are not there in lead 2, 3 AVF, then 90% it is not an MI. Okay, the other leads you can see to localize, but if either ST depression or ST elevation will always be there in 95 or 96% of the MI. The only exception will be a posterior wall MI, when where we have a AVR elevation and no depression at all and anywhere. So this is an acute anterior wall MI. We can see depressions in lead 2, 3 AVF, and we can see elevations in the lead V1, V2. This is an acute coronary syndrome, acute inferior wall MI, ST elevation 2-3 AVF, and anterior wall V2, V3, V2, V5. Now ECG changes as the MI heals. So once the MI starts to heal, with time the ST depression becomes flat, elevation becomes flat, and the T waves becomes inverted. The Q waves can persist as a permanent reminder of the old MI. Over time, T is inverted, usually become upright. So first we will have to see that there is ST elevation. Post that the STT will be okay, and we have T inversions, and then there is a deep Q waves. So this deep Q wave, it shows that the muscle is dead. So dead muscle will be shown as a Q wave. So once in an ECG you can see a Q wave, you can know that it is an old MI which was not treated properly, and the patient, that part of the heart is comparatively dead. So diagnosing abnormal Q waves, we can always see that these are the Q waves. So any first negative wave after P wave is a Q wave. So P wave, then Q wave, then R. So if the Q wave is more than 1/3 of the R, it is known as the pathological Q wave. So we can see here The R is very small, the Q is there, R is very small, Q is there, again Q is there, R is very small, more than Q. So this is an old inferior wall MI. The large Q waves are the pathological Q waves, usually seen prior to an MI. Then diagnosing abnormal Q waves, the Q waves in leads 2-3 AVF shows the old MI, abnormal inverted T waves V3, V4 and AVF. We can see this signs of anterior, and this is the inferior leads. This area is always already dead. Acute anterior wall MI, the Q waves in leads V1, V2 and V3. The evolution of ECG changes during an acute MI. So this is a normal ECG. Then we have a hyperacute T wave. The T wave you can see it become more upright. Then we have a ST elevation, followed by presence of a Q wave. Then the elevation it settles down and the T inversion comes, and later on the T inversion also settles down. If this is persistent later on, then that means that it is a old MI and the myocardium is dead. Now, what are the clinical importance? New right or left bundle branch blocks after an MI, a large MI or a poor, it shows a poor prognosis. Then ST segment elevation is more than one zone. Example, anterior and inferior pericarditis must be considered. ECG from monitor lead should never be trusted because they are always position dependent of the patient. It should always be taken by a machine. So this is not an MI, although patient is having, you can see ST elevation almost all the leads. This is known as a global ST elevation. The V1 to V6, all the leads are showing ST elevation. Then 2-3 AVF is showing ST elevation. Lead 1 AVL is showing ST elevation. So once we see this kind of picture, now we have two diagnoses in our mind. Either the patient is having an extensive MI involving all the three arteries, and in such a case we should see an ST depression in lead AVR. This is the only lead towards which the current will never go. So if there is depression over here, we can see that this is an extensive MI. The other diagnosis becomes a pericarditis, which is much more common. Any patient coming with chest pain, history of fever, having a global ST elevation, you can easily diagnose as a pericarditis patient. And one thing of importance, and even in pericarditis, tropi will be raised. So the cardiac biomarkers have no role in these conditions, and we should always consider involving a cardiologist. So reading an ECG, the computer ECG interpretations are never accurate. They are accurate for the intervals only, so we can take help to check the interval from the computer generations, but we will have to see the ECG ourselves. Computer read ECG should always be confirmed. The best way is to keep on reading the ECG and do practice. Then the abnormal T waves, you can see the ischemia. Then there is stroke where there is a small ST enlargement, the ST increases, interval increases. Then there is hypertrophic cardiomyopathy. You can see the sharp T wave. So in hypertrophic, what is happening? The left ventricle is unable to pump enough blood, and due to which there will be T inversions. So let's see a case. So 67-year-old man, diabetic, elevated blood cholesterol and hypertension, comes to the hospital complaining of feeling of indigestion. So the complaint is not chest pain, it is just an indigestion. In the upper abdomen, he is sweating and the blood pressure is 96/60. So three category of patients we should always remember. One is an elderly patient. Second is a diabetic patient. And third is a female patient. So these three patients, if they are even complaining of anxiety or ghabrahat or shortness of breath or any complaint, it should always be considered as an MI. The chest pain will not present in these three categories of the patients. They will never have a typical kind of chest pain. Mostly 90% of the cases, they will not have a typical chest pain. So even any kind of anxiety in these three categories, ECG should always be done. So when the ECG was done, now we can see ST elevations lead to 3 and AVF, and we can diagnose the patient as a case of inferior wall MI. So once we have diagnosed, we will manage, we will give the loading dose, and the cardiologist will do his job. He will go for the angioplasty, and this patient, he had a right coronary artery block. Stenosis was there and the PTCA was done. So another case. So this is a 17-year-old student comes to the hospital complaining of pressure under his sternum. The pressure lasted for 2 hours, get worse when he takes the deep breath. So the chest pressure, it is increasing with the deep breath. This is something known as the pleuritic type of chest pain. And once we are seeing this, we can diagnose the patient to either have a kind of pneumonia or pleural, or patient might be having some kind of pericardial illness is there. So once we get the ECG done, we can see a diffuse ST elevation, and note that there is no reciprocal ST segment depression. Even the AVR, there is no depression, and hence we are diagnosing him as a case of pericarditis based on the history and on the ECG findings. So this is the echo finding of the patient. There is small fluid collection in the pericardial region. The treatment, colchicine, ibuprofen. So now we move forward with the heart blocks. So what is the arrhythmia? Now we are dealing with the things that the heart, the rhythm of the heart is not good. It is not beating at a regular pace. So what is happening is, so here is the SA node, here is the AV node, bundle of His, and the Purkinje fibers. So how can a patient develop arrhythmia? Maybe the beat is not escaping the SA node. Maybe there is a conduction fault and it is not going from SA node to the AV node. Or maybe the AV node is not functioning, the beat is not going downwards, or there is some issues over here. So it can be a supraventricular arrhythmia, something happening above the AV node. It can be a ventricular arrhythmia, something happening below the AV node, or it can be an AV block, that the AV node is not conducting the things properly. The topic of discussion will be AV node only. So what is a heart block? A blockage in the cardiac electrical system can be a minor problem as a serious issue. Heart block can occur in the sinus node, within the AV node, below the AV node. Heart blocks below the AV node often results in a very low, slow heart rate requiring a pacemaker therapy. So what is happening is that the SA node has a beat of approximately 70 to 100. The AV node, it has a beat of approximately 40 to 60. And below the ventricular muscles, they have a beat of 40 or less than 40. So each and every muscle of the heart is made up of the myocardium. All of them can give you a beat. The only speciality of the SA node is कि उसका जो beat का rate है, it is quite high. क्योंकि यहाँ से beat high rate पे शुरू होती है तो others they do not have any self beat, they will follow it. If this is not creating the beat, AV node is creating the beat, then the heart rate will fall 40 to 60. If AV node is not creating the beat, ventricle is creating the beat, it will be 40 or less than 40. The interruption in the electrical conduction system usually occurs in or at the AV node. So it can be a first degree AV node, second degree AV node, or third degree AV node. So what is happening is, this is the AV node. Something can happen above it, at the mid, or below, at the AV node only. So this is will cause a first degree heart block, second degree, or third degree heart block. So what is the first degree heart block? Usually occurs in the AV node above or just above it. The PR interval is more than 20 milliseconds, or you can say more than 5 little boxes. The P arrow followed by a prolongation of the PR. So this is, you can see that the PR interval has increased. This is mostly a benign condition. So first degree heart block is a benign condition not requiring any treatment at all. The rhythm will be okay, pace will be okay, just there will be a prolonged delay between P and R, that is the atrial contraction and the ventricular contraction, because the AV node is functioning quite slowly than normal. So this is a first degree heart block. The PR interval is increased. Now, when we go for a second degree heart block, what is happening is that the AV node is damaged in the middle of the AV node. Again, the second degree heart block is of two types, the type 1 and type 2. So type 1 second degree heart block is also known as the Van-Kebek block or the Mobitz type 1 AV block, characterized by progressive increase in the PR interval leading to a missing of the QRS and the P wave. The sequence repeats consist of 3 to 5 beats with increasing of the PR interval. The last P wave is not followed by the QRS. So what is happening is PQRS, then P slight late QRS, P again delayed QRS, then there is a P but no QRS at all. So this drop beat is known as the Van-Kebek beat or the Van-Kebek block. Again, type 1 is a benign condition not requiring treatment as such. The block of the electrical transmission occurs just above or in the upper portion of the AV node. So here you can see that the PR interval is progressively increasing, and then there is a P wave not followed by a QRS. Again there will be a P wave and this will again repeat. So increasing PR interval in the first three P waves. The fourth PR interval is too prolonged to capture the ventricle, missing QRS. So here you can see PQRS again increase, then no beat. Normal, increase. So this is a type 1 of the second degree heart block. Then the type 2 second degree heart block. So also called a high grade AV block. This is known as Mobitz type 2 AV block, consists of a P wave that are repeatedly not followed by the QRS. A 3:1 second degree AV block is equals to 3 beats with each P wave followed by QRS, followed by a fourth P wave which with the missing QRS. The PR interval for the first 3 beats are normal. Electrical impulse of the fourth beat was blocked by the AV node. 2:1 AV block, impossible to tell if it is type 1 or type 2. So what is happening in second degree is there is a P wave followed by QRS, P wave followed by QRS. Suddenly there is a P wave but no QRS. There is no increasing the trend, there is no telling when this will happen. So here you can see that the PR interval is constant and then suddenly there is a P wave without a QRS. So this is more dangerous than the type 1, and this is a condition where you have to put a pacemaker. If you are not putting a pacemaker in type 2 AV block, then the patient will go into complete heart block anyhow. P wave not followed by QRS, complete heart block in or below the AV node, can be frequent with many drop beats. Implies serious disease with a conduction system, usually requiring a pacemaker therapy. So this is a 2:1 AV block. Here it is difficult to say whether this is type 1 or type 2 because there are only 2 beats. So we cannot say whether the PR interval was increasing or not. So what is happening is type 1 was that the AV conduction was delayed. So it was delayed, followed by drop, then a reset. So AV conduction was there. But in second type 2, what is happening is that there is a complete blockage of the AV conduction in the middle. So here we cannot say whether when it will stop completely. Hence we need a pacemaker. Type 1 can occur in normal or healthy individuals, is common with well-trained athletes and young people due to the increased vagus activity. Pacing is not needed in a type 1 Van-Kebek phenomenon. Then type 2, the block of the electrical transmission occurs below or in the lower portion of the AV block. Then there is a third degree AV block. So what is happening now that we are having a block below the AV node or just at the lower portion. So whatever the rhythm SA node is giving, AV node is getting it, but it is not transmitting below. So when the SA node is giving a rhythm, it is not transmitted below. The atria is contracting at the rhythm of the SA node. So atria is contracting at a rhythm of 70 or 80 because the SA node is normal. Now when the ventricle, it is not getting any rhythm from the above, it will start its own rhythm and it will be having a pace of 40 or less than 40. So now there is no coordination between atria and ventricle. It is contracting on its own like two separate, completely separate tempers. So what's the fault is that the blood will not know where to go. When the normal cardiac cycle, what is happening when the ventricle is dilating, the atria is contracting. So the blood will flow from above to downwards. But now when the ventricle is contracting, maybe the atria was dilating. Maybe when the atria was contracting, ventricle was also contracting. So in type 3 heart block, there is no coordination at all between the ventricle and the atria. Hence the flow of the blood is almost stagnant over here. The third degree is also called the complete heart block. The wave of deployation from the atria is commonly blocked. A subordinated pacemaker in the ventricle takes over. Markedly slower heart rates, wide QRS, unlike type 1 or type 2 where there was a narrow QRS. So this is the main point where you can easily differentiate the type 2 heart block and a complete heart block. Whenever the rhythm will come from the ventricle, the QRS will widen because ventricle has a slow rhythm pace. There is no regular relation between the P wave and the QRS. So here you can see a P wave, QRS, P wave, QRS. There is no rhythm at all. When will the P come? When will the Q come? There is an equal distance between the P waves and equal distance between the QRS. Now if we calculate with our rate method, we can find out this is almost 40 and this is uh, almost 80 or 90. The rate is there, the contraction rates of the atria. So let's see a case. An 88-year-old man with a syncope.